This video will cover the pathophysiology of insomnia as the most common type of sleep disorder or disturbance. At the end, I will also briefly touch on a few other types of sleep disorders. Insomnia is defined as trouble initiating and/or maintaining sleep, and it is associated with daytime consequences. Chronic insomnia is defined by insomnia that has existed or persisted for at least 3 months for at least 3 days per week. Insomnia in most cases begins in early to middle adulthood. As children develop, their sleep consolidates more and more to include more rapid eye movement or REM sleep. In early to middle adulthood, this balance begins to shift where more sleep disruptions tend to be present. In most adults, about 30 to 50%, insomnia is short term and usually will resolve when external pressures that are placed on sleep have been removed. However, insomnia can become chronic in about 9 to 12% of adults and upwards of 20% of the elderly. Insomnia is comorbid with many other psychiatric conditions, and 40% have a comorbid condition like anxiety, major depressive disorder, or substance use disorder. There are many factors that can contribute to either short-term or chronic insomnia. These include factors like the contribution of stressors like a separation, death, or job change, jet lag or shift work, an underlying medical condition like a cardiovascular, respiratory, chronic pain, neurologic, or being pregnant, a comorbid psychiatric disease like one I mentioned previously, or insomnia can be drug-induced by certain drugs that are CNS stimulants. These include drugs like the anticonvulsants, central adrenergic blockers, diuretics, SSRIs, steroids, and other stimulants like the amphetamine-based drugs. The best way to characterize all of these etiologic factors is to group them into predisposing factors, precipitating factors, and perpetuating factors. Predisposing factors are underlying genetic contributions or developmental contributions to the normalcy of sleep. Precipitating factors are things that might precipitate an insomnia event. These can be things like jet lag, shift work, or the presence of certain drugs, as I mentioned previously. Perpetuating factors are things that continue to perpetuate the existence of insomnia. And these can mean things like comorbid medical or psychiatric conditions. In the premorbid phase of insomnia, anyone with a genetic predisposition would be considered to have predisposing factors, although insomnia may not be very intense at that stage. Acute insomnia is defined by the presence of these precipitating factors like change in work schedule, jet lag, presence of drugs, on top of the predisposing factors that existed previously. If these factors are resolved, insomnia can be reduced or prevented. However, if perpetuating factors take on a larger role, like comorbid psychiatric or medical conditions, this can lead to the progression of chronic insomnia. The pathophysiology of insomnia is complicated and not very well understood, but in general is associated with hyperarousal or increased arousal. Some hallmarks of hyperarousal can be seen in the brain, systemically in the heart, and the HPA or hypothalamic pituitary axis. Things you may see include increased brain activity during sleep and increased arousals during REM sleep, increased daytime sleep, and shorter sleep durations. Systemic hallmarks include increased metabolic rate and increased body temperature. The cardiovascular system can display increased heart rate and altered heart rate variability. And the HPA axis will also show increased activity with increased release of stress hormones like cortisol. The neurochemistry of sleep and sleep disorders is also complex, but does include a very few very well-known neurotransmitters. These are important to review now, as these are the primary neurotransmitter systems that are targeted by treatments for insomnia. Certainly, the neurotransmitter GABA is involved in sleep-wake cycles, and this system is targeted by GABAergic drugs like the benzodiazepines and barbiturates, as well as other CNS depressants. Acetylcholine and norepinephrine are also implicated in the ascending arousal system, and these are targeted by drugs like histamine antagonists, alpha 2 agonists, and muscarinic antagonists. And finally, the orexin, also known as hypocretin system, is altered in insomnia, and there are drugs that target this system as well. We will return to this figure when we talk about treatments for insomnia in a subsequent video. But for now, suffice it to say that the neurotransmitters involved in the production of insomnia include GABA, acetylcholine, norepinephrine, and orexin. Dopamine may also play a role in some of these pathways and should not be excluded. The DSM-5 actually contains 10 different categories for sleep disorders. We will focus only on insomnia here. Diagnosis of insomnia requires that the patient be dissatisfied with sleep quality or duration, as well as having the presence of other daytime symptoms. That is very important because, by definition, insomnia must cause distress or affect daytime function. To be considered chronic, it must occur for at least 3 nights per week and last for at least 3 months. Some of the nighttime symptoms include difficulty falling asleep, frequent or prolonged wakenings, and early morning awakenings, whereas the daytime symptoms include fatigue, reduced energy, impaired concentration, memory, or attention, mood disturbances, and difficulty functioning in social or occupational settings. There have been some recent changes to the diagnosis of insomnia, and although I won't spend much time going through these, I did want to display them here because there is one important difference that recently occurred in the diagnostic criteria. Previously, there used to be a distinction between primary and secondary insomnia, which is to say secondary insomnia would be related to another medical or psychiatric disorder. This distinction has been removed, which eliminates the need to make an attribution between insomnia and other comorbid conditions. However, I wanted to present it to you now because you may still hear some diagnosis characterized as either primary or secondary. One of the diagnostic tools available to diagnose insomnia and other sleep disorders is called polysomnography. This is the type of test or a sleep study where individuals wear various electrodes and other recording devices on their body during daytime sleep and or nighttime sleep to assess and record various sleep variables. Again, this can aid in the diagnosis of various types of sleep disorders. There will be electrodes attached to the brain to measure brain waves in electroencephalography or EEG. Eye movements can be monitored using electrooculography or EOG. Muscle movements are recorded using electromyography or EMG, and heart and cardiovascular function is evaluated using electrocardiography or ECG. There may also be a microphone to record sounds, a way to record nasal airflow, a thoracic and abdominal belt to measure breathing and resistance to breathing, and a pulse oximeter to measure oxygen saturation. The results of all of these recordings over a nighttime of sleep will provide significant information to help diagnose the specific sleep disorder. There are several other types of sleep disorders that exist, and these include conditions like hypersomnia, which is increased sleep, narcolepsy, which is associated with excessive daytime sleepiness and disrupted nighttime sleep, with or without cataplexy, which is rapid, immediate loss of muscle tone. Sleep apnea is characterized by repetitive episodes of stopping breathing during sleep, followed by oxygen desaturation and brief arousal to reinitiate breathing. There are also several types of parasomnias like REM behavior disorder, sleepwalking, and night terrors, which in general are characterized by abnormal behavior or physiologic events that occur during sleep or that are exaggerated by sleep. And finally, there is also restless leg syndrome, which is a specific type of paresthesia that's felt deep in the muscles of the lower extremities, and it results in the urge to keep the limbs in motion. This may keep individuals awake for long periods of time. In addition to insomnia, both narcolepsy and restless leg syndrome also have the possibility of being treated with therapeutic drugs, whereas many of the other sleep conditions are treated using non pharmacologic treatment options, such as CPAP for sleep apnea. To continue your learning about insomnia, snap a pic of the QR code to access a short video about insomnia pathophysiology, which lasts less than 5 minutes.